Today's video, we're going over surgical versus non-operative management of SLAP tears. Kevin, what is a SLAP tear?
Oh God, I can't remember, dude. We haven't talked about it in a few weeks.
Yeah, we film a lot of these back to back, so we literally just talked about SLAP tears for the past like hour and a half. So,
Yes. So, yep, SLAP tear is that superior labral tear, anterior and posterior.
mm,
So, yep,
everyone's
good stuff.
favorite type of labral tear.
Yep.
But what are we going over today?
So, we're going over surgical versus non-surgical management for SLAP tears. So, something that would be good for PTs to know. And we thought this was a pretty good paper by Steinmetz et al. And it was published in 2022, excuse me. And the title was Return to Play Following Non-Surgical Management of Superior Labrum Anterior Posterior Tears, a systematic review. So first paper, non-surgical management.
This seems juicy. I cannot wait for you to dig into this one.
All right. So just a little bit about the methods. It was a systematic review, and they were following the PRISMA guidelines for development. And they were analyzing return to play rates. And then I think that often gets overlooked when we talk about return to play is returning to your previous level of performance. So that's another interesting thing they were looking at, because to get back to CrossFit or to get back to baseball or whatever sport that you love is one thing, but to get back to it at your previous level is obviously the goal, previous level or better, right? I think getting back and just participating definitely lets a lot of people down. So I thought this was really cool that they were looking at both things.
I think that's really important because I think we all pat ourselves on the back when we say like, "Oh, this surgical repair had a 80% return to sport rate," but are they actually returning at the same level that they want to? And the thing you'll also see in some of our medical literature, and this is in the rotator cuffs, I won't give away some of the stuff we're going to go over in a minute, is that what happens is that the return to sport at previous level is higher in individuals that aren't getting back to that high of a level of competitive play. So if you're a professional pitcher and you have a rotator cuff repair, the chances of you getting back to sport at the same level are going to be lower than if you have a rotator cuff repair and you're 60 years old and trying to get back to soccer. You know what I mean? So what you will see sometimes in medical literature is that the higher level of competition you want to get back to, the worse your chances of getting back at that same level. So I think it's really important as physical therapists that when we're trying to give our patients some advice on whether or not they should get a surgery, we have to talk about this. It's like, okay, well, your return to sport rates are X, but there's actually a good chance you might not be playing at the same level. Are you okay with that risk? Right. And I think with the SLAP tears, and we'll talk about this in a little bit, is that they actually tend to do pretty decent with just conservative treatment. So it's not like you get a SLAP tear and your shoulder's back to 100%, right? And we may actually be able to do a pretty good job just conservatively. So again, important for the physical therapist to think about this and just know both ends of the spectrum in terms of like what's to be expected, conservative versus surgical management. I don't know if it's the ends of the spectrum make any sense, but we're going with it today.
Awesome. So a little background about this systematic review. They included 5 studies with a total of 244 athletes, and they were a relatively younger population. So the age range was between 22 and 38 years old. For a diagnosis, they had to have an MRI, which showed a SLAP tear and or a positive clinical exam finding. So the clinical exam finding that they used was a positive active compression test. So that positive O'Brien's test, a compression rotation test, a biceps load test, and or tenderness over the bicipital groove. So we did talk about some of the challenges with special tests in a previous episode. Check the show notes.
Show notes.
But I think it's the best we can do for these types of studies. So just understand that that is a limitation of the study, but it's something that we have to roll with in terms of the diagnosis. So the most common that the authors noted for a type of SLAP tear was type 2, like we've talked about. And it was a mixed cohort of traumatic tears and atraumatic tears. So again, potentially, a limitation. I don't know. It's hard to get all the same type of patient population in these systematic reviews. Um, the mean follow-up was between 12 and 24 months. So they were looking at how these folks progressed non-surgically over the course of a year or two. And many sports were included. I think almost every sport you could imagine was in the study, but there were some ones that were more common than others. And that was baseball, softball, weightlifting. So a lot of our overhead sports. I think swimming was pretty common too, but a lot of sports were included in the study.
Very good. Couple things there. I'll just note on that limitation first. I actually think it's pretty important. And I wasn't aware of this because before I came to Champion Physical Therapy and Performance, I worked with athletes, not as many as I do currently. And I like to think that I was kind of staying on top of the data when I came to Champion, and I was kind of quoting these return to sport rates for like kind of slap tears and biceps tenodesis. Lenny was the first person to say, well, like, well, the return to sports decent, but not maybe as much for baseball pitchers, right? And I think it's a little bit unfair to lump everyone together and look at return to sport rates. And I'd be curious, like, what the return to sport rates were for the weightlifters versus like the baseball pitchers. So I think you may find quite a bit of difference. And then it skews your reasoning in terms of like, is this surgery good or appropriate for the athletes in front of you? Because we'll talk about this a little bit later, but return to sport at a very high level for a CrossFitter for like a biceps tenodesis is amazing, but return to sport slap repair for maybe a baseball pitcher, not quite as good. So if you lump everyone together, those results get skewed a bit, right? So it's important to keep that in mind. The other one I wanted to say is that historically, and this is starting to be challenged a little bit, surgeons will generally perform a slap repair on younger patients. Let's say an overhead athlete under the age of 30. Typically, they're going to be getting a slap repair. For athletes or individuals over the age of 30, typically they're going to get more of a biceps tenodesis from a surgical perspective. Like I said, this might be changing a little bit in the future. I think it's changing a bit based on the surgeons that I follow. But we'll talk a little bit more about this in future studies, in the next 10 minutes. So stay tuned with that. And I think that's it. That's all I had to say about those things, Kevin. To go along with today's video, I have a free evidence-based cheat sheet on slap tears. I'll get you up to date on all the literature on slap tears in under 10 minutes. We go over anatomy, prevalence, and risk factors for getting a slap tear. We go over the mechanisms of injury as well as a clinical presentation. We cover differential diagnosis as well as diagnosis. What are the best treatments for slap tears? Is surgery effective for a slap tear? And is physical therapy better than surgery for slap tears? Lastly, what are the return to sport rates for slap tears, both conservatively, so with physical therapy, versus getting a surgery, so either getting a biceps tenodesis or slap repair? It's a 5-page PDF. It's 100% free. I'll leave a link in the description. Go ahead and click on that and download it and get back to this video.
So just looking through the study, they included a synopsis of the rehab protocols that were used in these 5 different studies. And generally, it's pretty progressive of things that would think about in PT. So the initial phases were decreasing inflammation. So maybe a little bit of activity modification. There was selective use of NSAIDs. In some cases, there were subacromial steroid injections for these people non-operatively undergoing rehab. The clinicians in these different studies were addressing GIRD, which is something we could talk about. So that's a gleno-humeral internal rotation deficiency. So they were trying to essentially improve internal rotation range of motion. And then they were looking at scapular dyskinesis, which is probably the most controversial diagnosis in PT. But yeah, anyway, so probably some rotator cuff strengthening, working on the posterior capsule to improve internal rotation, periscapular strengthening. That's how I think of that. And then for return to sport criteria, the patient had to be asymptomatic. They had to have full pain-free range of motion, and then complete sport-specific goals. So pretty broad return to sport criteria, but each study had their own things that, broadly we're looking at these 3 things here.
Yeah, which is good. And I think they are broad, but the other part is that I think they're still decent. So if you're kind of non-operatively managing your athlete, you kind of want to get to that point, right? Essentially get to the point where they don't have symptoms, get their range of motion back, and then you got to put them through a battery of probably strength testing, but also return to throw, which we'll probably talk about in later podcast episodes. But if you're trying to get back to throwing, we probably need a really good interval throwing program to get folks back. So basically, get their symptoms away, increase that range of motion, and then get a little bit more specific over the course of time to whatever activity that person wants to get back to. The other thing I just wanted to say, and it's just a little bit about GIRD. I think that anytime I hear GIRD in a research study, we probably have to mention that that's outdated. You know what I mean? Don't just start stretching every single person that has internal rotation deficits into more internal rotation. We see GIRD. Lenny jokes about this all the time. Every single doc that diagnoses, let's say a SLAP tear, they'll say GIRD, scapular dyskinesis, treat those two, right? What we know is that as you throw growing up, we gain external rotation, we lose internal rotation. I've seen so many athletes that were diagnosed with GIRD and they have reduced internal rotation, but they have an insane amount of external rotation. And they're actually quite lax individuals, meaning that they have a lot of laxity within that capsule. They just threw growing up, so they have bony changes, and now give them a lot more external rotation and a lot less internal rotation, right? So if you have a lax person and you start stretching them more, is that helpful? I would argue probably not. So you just want to make sure you look at that total arc. Now, what are your thoughts on that, Kevin? I know that's something you treat a lot more than I do.
Yeah, I think you summarized that well. So that's a concept that we all utilize at Champion, working with overhead athletes, is just understanding that their anatomy is a little different and their dominant versus non-dominant arm. So it is about adding up that total arc, external rotation plus internal rotation, and comparing to the other side, and just understanding that the total arc side to side should be relatively close. But when we see someone with, we see people with up to like 140, 150 degrees of external rotation, which is wild. And then that same person might have 20 to 30 degrees of internal rotation. And then on their non-throwing side, maybe they have 110 of external rotation and 60 or 70 of internal rotation. So that's not something that we can correct. It's a bony change. There's a retroversion of the humerus. So we have to just let that be. And, working on soft tissue work with these people might be helpful, but stretching, particularly the one that people would use in the past is that sleeper stretch to improve internal rotation. That's probably something that's just going to irritate these folks because it's not range of motion that they have available, and it's not something that stretching is going to improve. So that's an important concept to keep in mind.
Yeah. I'm not even going to go into the scapular dyskinesis. I just did a pretty big video on rotator cuff related pain. And I talked a lot about posture, scapular positioning, and I started diving into scapular dyskinesis. And I immediately was like, too deep, need to get out of here. It's too much. It's so nuanced. It's kind of a crazy discussion. So I'm just going to completely skip and ignore it for today's lesson anyway.
Yeah, good. Okay, so diving into the results. So after non-surgical treatment, the return to sport was 53.7%. And then the return to prior performance was 42%. But there was an important differentiation between these folks. So in the group of people that were able to complete rehab, so they were able to complete their full course of rehab, they didn't have to stop because they felt they needed surgery or they didn't drop out for some other reason. Those folks who completed it returned to sport at a rate of 78%. And the return to prior performance was a rate of 72%, which is really, really good. So if you're getting back to sport, according to this study, there's a high chance that you could get back to your prior level of performance with non-operative treatment. And so they looked at, just with subjective outcomes, 3 of the studies included, looked at the American Shoulder and Elbow Surgeon score and the pain, just a pain score, a VAS pain score. And with those as well, they showed significant improvement pre and post treatment. So, completing your rehab seems to be super important. And I think if you do, there's a pretty good chance that you could get back to the sport you want at the level you want.
When I first looked through this study, I was just kind of breezing through the abstract and I was looking at the return to sport rates. I was like, dang, that's not that good, Then you read a little further. It's like, well, if you actually finish the rehab, you do pretty good. And I thought that was a little bit hilarious, right? And two thoughts there. So, A, if you do a good job with rehab, those return to play, return to sport rates, I think are actually quite high. But it also underlines the importance of actually finishing your rehabilitation. Oftentimes, you're going to be working with, let's say, younger high school athletes, and they have another sports season coming up, or they're trying to get back sooner, right? And I think it's important to just educate those folks, just say, like, hey, if we skipped steps, like, you're probably not going to do as well. And here's some research to support that. So I think long-term planning becomes really important for these athletes to say, like, okay, let's figure out what's truly important to you. Because if we don't go through rehab fully and go through these steps, become asymptomatic, return to sport, interval throwing program, all that stuff, your chances of getting back are going down. So just have to think about that when an athlete comes in. Like, when is their next season? Are they in the middle of a season? Like, how do we best manage that athlete? And I thought there's some good information to help us with that.
Yeah,
Boom.
that's a great point. Just creating buy-in. I think like for these, especially for these younger kids that they want to get back to their sport and they're like, how's PT going to help me? I think that's some useful information we can share with them. So a little further on the results. So how long was it taking these folks to return to play? On average, it was between 5.2 to 5.7 months. And there was a range anywhere between like 3 and over 6 months. So I think it's going to depend on the person. But if someone comes in and they have an MRI, so they just got diagnosed with a SLAP tear, they're pretty painful, and they want to know how long can I expect to return to sport. I think this is a helpful figure. So, maybe anywhere between 4 and 6 months or so. Just keep that in mind. Um, and for those people who completed rehab, what was the average visit number? So, in this particular review, combining those studies, the average visit number was 20, and there was a range between 8 and 28. So, I think that's going to depend on the individual and that type of thing. But it's something that I think they need to be prepared to put some work in for. That's how I read that. It's not something that's going to get better with one visit and education. For most folks, they're probably going to need to come in and see you for a while and get a really good program. Um, what were the factors that predicted a failure of non-op rehab? So they tried to look at this a little bit. One study showed that playing overhead sports was something that could make returning more challenging. Having a traumatic injury versus that chronic degenerative type injury, which I think is interesting because that's kind of like the opposite of a lot of overhead sports. But and then a positive compression rotation test. One study showed if you have a concomitant tear of your rotator cuff, that was more challenging for getting back from non-op rehab. And one study showed being an older age. So if you're a 25-year-old pitcher, it might be a little more challenging for you to get back than a pitcher who's 18 or 19 years old. Being a pitcher was more challenging to get back versus a position player. A longer career, which goes along with age, a longer symptom duration, again, which probably goes on along with age, um, and a concomitant cuff tear or a Bennett's lesion. So just some other factors to predict, to help your decision making. You have someone come in with they're older, they're a pitcher, they've had a long career. Um, Maybe they didn't have a slap tear in the past, and this is new. Maybe that's someone who this will be challenging for. But I think regardless of these are things to keep in mind. But you can go ahead and try the non-op rehab and see where it takes you.
And some of those were a little sad, if you're an overhead athlete, probably going to do a little worse. If you're a pitcher, probably going to do a little worse. Those are the folks where you're primarily thinking that you want to rehab that slap injury as best as possible. And I think, unfortunately, is that, you can try surgical management if you don't do well conservatively. But the problem is that the folks that want to get back to a really high level throwing are the same folks that are probably going to fail some of the less conservative or surgical rehab. Not to say that they can't have success with it, but I think the higher level you're trying to get back to, the harder it is to return. So I think the other part too is that it just seemed like more concomitant pathology and even age. Those folks are probably going to tend to have more concomitant pathology as well. It's going to make it a little bit more challenging. And what I will say is that if you're getting into the whole realm of full thickness rotator cuff tears, probably want to think about potential treatment for that surgically, maybe if that's a player, right? And not just the slap. If you want more information about rotator cuff tears, I'll maybe put a link in the bio, in the description to check out some additional information about whether or not you should get surgery for rotator cuff tears. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain Free mini course. I've made an absolutely free mini course and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning.
Yeah. All right. So some of the limitations that, I did mention a little bit, but in terms of the diagnosis, it still seems challenging to diagnose SLAP tears, whether it's with an MRI, with a cluster of our special tests, whether it's palpation. Just something to keep in mind with this study is that it is challenging to diagnose unless you're actually in there surgically to know exactly what's going on. One thing that just came into my mind was that for folks that are managed non-operatively, if they're, the follow-up was, the period of 1 to 2 years. I just wonder if over time, if there was like repeat imaging, does stuff get worse? Does a tear of just the labrum, if you have just a labral tear like a type 1, are you at risk of fraying or tearing the biceps? That's hard to know because we know sometimes with partial thickness rotator cuff tears, sometimes they go on to become full thickness. So, I don't know if there's something similar that might be happening non-operatively with a SLAP. That's just something, I don't know. We got to look into a little further. Not enough understanding how or if the type of SLAP tear predicts success or failure. So with this particular study, did the type 1s do better than the type 2s? Did the 2s do better than the 3s? I think that's, a potential limitation, but unless someone comes in with a diagnosis, you're not going to know that anyway when you try your non-op rehab. And then I just didn't see a great description in this review paper. I didn't go into all of the articles individually, but just wondering why these people failed conservative care. Was it adherence? Was it pain that stopped them? Was it returning to sport? They had successfully completed the rehab program and then they try to get back to sport and they were calling that a failure. So I think just a little more information on that would have been helpful in terms of the study limitations.
Yeah, and I kind of wonder about this too. Like, if we're letting some of these slap tears go, are we potentially causing worse pathology eventually that we can't really address? If we're letting that bicep tear, are we going to be creating more rotator cuff issues over the course of time? I think there's a lot of questions that we don't have really great answers for. The other thing I wanted to say is that, yeah, we want to make sure that this slap tear is not getting worse and worse over the course of time. Nothing to keep in mind is that in slap repairs, the re-tear rate is actually decently high as well. So it behaves kind of similar to a rotator cuff repair. As much as we would like to think that you repair that rotator cuff and it's good for the rest of your life, there's a fairly high revision rate for rotator cuff, not revision rate, excuse me, re-tear rate. The same thing occurs with slap tears. They can tear again, right? And unfortunately, I've seen that in several athletes and been treating them conservatively after their after their slap repair. So that does happen as well.
So here, just conversely, instead of looking at non-operative tears, um, we're going to look at a return to sport after the surgical treatment of a superior labral, anterior, and posterior tear, a systematic review. And this was in the Orthopedic Journal of Sports Medicine in 2019.
Good year.
That was a good year. That's the year I graduated PT school.
Nice.
Yep, 2019. All right. So this was a quote from the paper, but a recent systematic review shows average return to sport after surgical repair to be 80%, but unclear on the average age and what sport they were returning to. So that's a really good number, 80%. When we look at what type of surgery is going to be occurring for these people, we see a slap repair and we see a biceps tenodesis, I think is the two common surgeries. So in this study, 501 athletes, so they were looking at athletes, met the inclusion criteria, and 195 of them went on to get a slap repair. And what they found here was that the average age was 31 years old, and 79% of people with a slap repair, average age 31, went on to return to sport, and 63% of them went on to their prior level of sport. So with the slap repair, I think those numbers are decent. I think those are relatively similar to the non-operative treatment. 222 patients underwent a slap repair and a rotator cuff debridement. So these folks also had a little rotator cuff pathology. It was debridement, it wasn't like a repair. The average age was 22 years old, and 76.6 of them returned to sport, but only 66.7 returned to their prior level. But again, these are pretty good numbers that I think are comparable to our non-operative treatment. And then 84 of these patients underwent a biceps tenodesis. These folks were a little older, so the average age was 42 years old. Now, these numbers are even better. So 84.5% of them returned to sport, and 78.6 returned to their prior level of sport. So, I think looking at these numbers for slap repair or biceps tenodesis, we have pretty good return to sport rates and return to prior level of performance, I think, that are closely in line with non-operative management. So I think that gives me a pretty good feeling for both. If I had to treat someone non-operatively, we have decent odds. If we have to treat someone operatively, we also have decent odds. So, I don't think it's the end of the world if some of these folks have a surgical repair or a biceps tenodesis. But, I think we'll talk about this, but what they're getting back to might matter a lot too.
I was going to note on that a little bit. Yes, I agree with you. It's kind of like if you have a slap tear, treat it conservatively. And if it's not going well, you can try surgery. It seems like we actually do pretty well when we do surgery as well. The other thing I want to note on was the biceps tenodesis. A few things, and I had said this before, but largely in the surgical world, if you're under the age of 30, usually we consider slap repair for you. If you're over the age of 30, we more consider biceps tenodesis. So I think that's why you see that skewed to the 42-year-old athlete. Also, the tenodesis rates were a little better than slap repairs, right? Which makes you think, like, well, why would we do a slap repair if the biceps tenodesis is better? I think that's actually a little bit unfair for the reasons I kind of mentioned earlier. So if you're a 42-year-old athlete, you're probably not getting back to professional sports, right? You're Probably not playing Division I athletics. That'd be really weird as a 42-year-old playing with a bunch of 20-year-olds, right? So part of my thought is that the level of competition you're trying to get back to is a lot lower. So probably have a better return to sport rate and probably have a better return to play rate at the same level, just because you're not getting back to something that's at high level of competitive play, right? I'm like right around that age now, and anything that I do competitively is nowhere near as competitive as it once was when I was a 20-year-old. So I think just take those numbers with a grain of salt. But just like Kevin said, that's pretty promising, right? That's a pretty decent number. And anecdotally, I see a lot of success with the biceps tenodesis myself. So I do like that surgery. All right. So I'll talk a little about biceps tenodesis because I just said I liked it, right? Well, I have a few studies here, and the first of which is going to be a study in SLAP tears. And basically, they're younger folks. So the average age was 21, because I had just mentioned that generally speaking, if you're under the age of 30, you're going to get SLAP repair. If you're over the age of 30, you're going to get biceps tenodesis. Well, what happens when you do biceps tenodesis to a 20-year-old, right? So this study by Waterman et al. In 2023 was looking at that. And there's only 16 patients, so take this all with a grain of salt. It's not a huge study, but at least we can start to get some answers here. And they were looking at a variety of different types of patients, which can be problematic, right? Because different sports have different demands. But they included baseball athletes was the largest group, followed by softball, followed by gymnastics and swimming. There are also some other athletes. They didn't mention what they were, but predominantly throwing athletes, right? And they did a primary tenodesis. What that means is that the first surgery that they got was a tenodesis, not a SLAP repair. What does often happen in folks have SLAP repair, all right, and I have a patient on my schedule right now who's undergoing this, is if you have a SLAP repair, it doesn't work, then what they do, or if it tears, they do a tenodesis afterwards, right? So it's common to see these secondary tenodesis, and then if you're looking at secondary tenodesis outcomes, maybe they're not as good, potentially because it's the person's second surgery. But this was the first surgery. They started with a tenodesis, right? And what they found is that 81% returned to sport at the same level of competition, which I thought was wild. I thought that was great, right? So they're young athletes and they pretty high return to sport at the same rate, right? Which is more important than just return to sport. And the other thing I thought was wild was the average return to sport time was 4.1 months after surgery. And my first thought was like, dang, that's fast. You know what I mean? But a couple thoughts, right? So A, that was a better return to sport time frame than conservative management, right? So one of my thoughts is like, okay, if you do surgery for an athlete, the thought is like, all right, we're going to have to take a lot of time to rehab. Okay. It's not necessarily the case with some of these athletes. So I think the average return to sport up was like 3 to 6 months, right? And the average was around 5, something along those lines. The average here was 4, right? So I thought that was very quick. To be honest, I would be uncomfortable returning someone back at 4.1 months. I think that's extremely fast. I mean, even my CrossFitters, like I'm 6 to 7 months, right? They're kind of ready to go. That 4.1 sounds crazy, but that's what that research study showed, right? And another study I wanted to mention, and this goes back to this idea that not all athletes are necessarily going to get back to sport at the same rate, just because there's different demands of each sport, right? And this is a study by Carbone et al., and this is in CrossFitters. And I love this study. I think it's great. What's funny about this study is it wasn't in predominantly SLAP lesion patients. It was actually in predominant rotator cuff patients. So every patient in this study had some sort of rotator cuff repair. I think it was greater than 50% partial or full thickness rotator cuff tears, right? And what's pretty interesting is that these were very competitive CrossFitters. How do I know that? The average amount of time training they spent per week across all the subjects was 15 hours, right? If you're a recreational CrossFitter, you're doing like 3 to 5 hours. You're not doing 15. If you're doing 15 hours of training each week, you're one of those CrossFit like mega enthusiasts, or you're very competitive, right? So I thought this was good because we're looking at return to sport at a higher level of CrossFit. This is not just the run-of-the-mill individual. And like we said before, I think if you're looking at run-of-the-mill individuals, you're probably going to do even better as long as they do a good job with the rehabilitation, because their expectations are lower. They're not trying to get back to the same level of competition, right? So there are 22 participants in the study. All 22 had some sort of rotator cuff repair, but 15 out of 22 participants also had a biceps tenodesis, right? So 3/4 of these folks, not completely, but around 3/4 of these folks had the tenodesis with a rotator cuff repair, right? And what they found was a 100% return to sport rate. So everybody got back to CrossFit, right? And this was with concomitant pathology, which we know is one of those things that reduces your return to sport rate. Okay. The other piece is that they asked them at the 2-year mark, so pretty far out, whether or not they felt like they returned at the same level or higher. And what's really interesting is that 91% returned at the same level or higher. And the folks that got back better than what they initially had was pretty high as well. I don't remember that number, but I think it was around 50%. It was around 50% felt like they got back to a higher level than where they were at previously at the 2-year mark. And then 30% was at the same level. And then it was, I think, around 9% would be the math, right? For folks that basically didn't feel like they returned at the same level. And there were some re-tears in there as well. I think 22% of folks retore in the rotator cuff. They didn't have a tear of that tenodesis, right? That's kind of hard to do, but it can happen. But there was, a fairly high re-tear rate of the supraspinatus or infraspinatus, and they still had a 91% return to the same level of play, right? So I thought that was interesting. Like I said, I see a lot of tenodesis come through. I work a lot with Dr. Sean Rocket. I always say he hates biceps tendons. He's constantly cutting them. You know what I mean? But I think that's because these return to sport rates are really high, and people seem to get on just fine without their biceps tendon. I've had several games athletes with biceps tenodesis, and they just get back and they feel great, and it's just seems to be a really good surgery for them. And they're competing at the very highest level of competition. So yeah, I do like the tenodesis for those folks specifically. Anything to add to that, Kevin?
Very interesting. One thing that popped in my head, just wonder if it's like a testament to CrossFit athletes, and if you go into a surgery like that, super, super healthy and fit, these people that are training so much, do they just have better rates than some other people? Um, that's what popped in my head. I mean, 100% return to sport, that's amazing. I know it was a small cohort, but those were very fit cohort. So,
Yeah.
I think it's good to know that the tenodesis isn't career ending for them if that's something that they need. Um, but I wonder if it's how fit those folks are that they do so well, and maybe they do well with any surgery. Just beasts.
Yeah, that's an important point, right? So most CrossFitters, they're very adamant about their health. They'll do kind of whatever it takes to improve their health and kind of get back to things they love. So you probably have a sampling bias there, right? These people are going to be good rehabbers, going to do whatever it takes to kind of get back to doing that. I tend to think about like my 15-year-old male that has a slap repair, does not understand what's going on in the shoulder, doesn't understand the amount of work they have to put in, right, in order to get back. And you're just trying your best to get them to kind of go through with the rehab. And obviously, it's very different from person to person. Some people are phenomenal at the rehab. But you do definitely get a subset of people that don't really rehab quite as well. So to your point, there probably is a bias there. These folks make it back just because they're doing a better job, right?
Just to summarize a little bit about talking about non-operative versus operative care, and when to refer a patient for potentially a surgical repair or biceps tenodesis. I think what we see clinically a lot of times is that we're working with, say a baseball player or something, and during the rehab, their symptoms get better and better. And then we return to throwing. And if you don't have a good plan in place for returning to sport, these folks might fail non-operative rehab. But I think a lot of the times we just need a better return to sport plan. So I think, potentially in a future podcast, we'll talk about that full return to sport phase for something like a SLAP tear. And when people get symptoms, oftentimes it's back. I'm thinking about baseball specifically because we see so much of that at Champion, but they'll be undergoing a throwing program. And if it's not a throwing program that makes a lot of sense in terms of building workload in a progressive manner, that's when they'll get flared up again. And that's when their arm will hurt and they won't be able to return to sport. So I wonder if the non-operative rehab numbers could be even better if we have a good return to sport program in place, with like a progressive build back to throwing, or once they are throwing, that they're not, they're not jumping so much week to week. It's not like you're throwing at 60 feet. You played light catch today, and then you're doing a bullpen tomorrow because that felt good. Because that's going to irritate someone's shoulder, and is that someone that really failed rehab? I'm not sure, but I think that's when we'll see people who, that they truly do fail, is they feel good through a lot of the non-operative rehab. They're doing a good, solid throwing program that we know isn't spiking workloads too quickly, and then their shoulders really hurting them. And in my mind, they can't get back to what they want to do. This is someone that might benefit from one of the surgeries you were talking about. So I think that's just something to keep in mind too, is when we're thinking non-operative, we have to make sure we have good plans in place for that rehab portion.
So now you guys have an idea of whether or not your patient should undergo surgery for SLAP tears. We did mention how rotator cuff tears can be a concomitant pathology with these. So if you have a rotator cuff tear, should you get surgery? Should you not get surgery? Well, we have all of the answers. I'm going to leave a link above Kevin's head here. Oh, yeah, right up there. Once you click on that, and in that video, we'll go over whether or not your patient should undergo surgery for a rotator cuff tear. See you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start it for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.